Thank you. That was great. I just feel like we brought so many different communities into the room with that panel and really just scratched the surface of understanding the type of work they do, why they do it, and some of the challenges that exist in doing this work, and flipping the frame also, I think, on some of the traditional ways that we think about community. So I have to say I'm extremely happy to be able to introduce Charlee Alexander, who will be moderating the next panel of some more fabulous, amazing community folks who are working, again, across the country in three yet different communities. And so we'll hear from some of the work they're doing. But Charlee is a program officer at the National Academy of Medicine. She co-manages the Culture of Health program with me. And in addition to that, she also directs the Action Collaborative on Clinician Wellbeing and Resilience, which is a network of over 50 organizations committing to reversing the trends in clinician burnout and improving the well-being of healthcare professionals. So Charlee will be joined by Ezra Bayles, who is the Division Director for the Taos Pueblo Division of Health and Community Services. And he moved to Taos Pueblo, New Mexico in 1993. He got his BA in geology. I told you I'm going to pick out some unique things that bring diversity to the conversation. So his BA in geology from Colorado College, and he is currently in a master's in public health, or he's a master's in public health candidate at the University of Arizona. So he has a little bit in common with Charlee, who is currently also getting her master's in public health from Johns Hopkins. Darrin McCormick is the community liaison for the Williamson Health and Wellness Center in West Virginia. He has devoted 27 years working for a local community bank in Williamson, Mango County, West Virginia, wearing many hats. He was a loan officer, compliance officer, secretary of the board of directors, and community reinvestment officer. And he served as mayor of Williamson from 2005 to 2014. And in 2014, Williamson was designated as a Robert Wood Johnson Foundation Culture of Health Prize winner. So our other panelist, Lisa Mitchell-Bennett, is a senior research associate and the project manager at the University of Texas Health School of Public Health. And in her role, she manages a large portfolio of health services, her service delivery projects, including youth obesity intervention, delivered in 3 school districts, chronic care management system, and works with numerous partners there. And she's a community, she works with a program that is also a community advisory board that's working to integrate the arts, economic development, and health. And she has her master's degrees in international development and public health. So Charlee, take it away.
Great, thank you very much, Kimber. Ivory, can you put the slides on the confidence monitor? So full disclosure, this is my first time moderating a panel, so we'll see how it goes. I think it'll go well. So this is our session today, definitions, challenges, and solutions to achieving health equity in communities across the United States. I'm Charlee, and I'm joined by my esteemed panelists, Ezra, Darrin, and Lisa, who we had the pleasure of meeting over the summer. So the objectives of the panel are really to learn how communities define health and health equity and health disparities, and what some core principles are that they use to guide their work in addressing the social determinants of health. In addition, we would like to discuss what factors and approaches are transferable across communities and what are unique. Before we dive into the panel, I just want to give a brief overview of the community level work for the Culture of Health program at the NAM. So the first phase of this work took place over the summer during what we called our Listen and Learn tour. Essentially, it was a whirlwind tour around the United States. I was on the road every week for about 9 weeks. It was really intense, but really fun. And I really appreciate all of those who we visited. You welcomed us into your communities. You shared some important thoughts, and I just really appreciate your openness, and it was an enriching experience, so thank you very much. So I went on all of the visits, and then my colleagues split some of the other visits, and I think we overall had a really good time. It's always nice when we can get out of the office into communities and to really see the good work that's going on. So the phase one of the work, the goals were really to identify leading communities and understand the process through which they've advanced health equity. So we've heard a little bit about what happens in one community won't necessarily work in another community. But can everybody hear me? Okay. So what happens in one community might not necessarily work in another community, but we wanted to know if there were some common principles that could be transferred across communities. So we wanted to see, for example, if there were themes in leadership or measurement or sustainability that we could elevate and bring to other communities who were not as far along in advancing their health equity agenda. So these are the communities we visited this summer. We did 11 community visits. So maybe just quickly, if we visited you this summer, if you want to throw your hands up. Yeah, awesome. So we went to Brownsville and Buffalo, Columbia Gorge Region, Oregon, Durham, North Carolina, East Los Angeles, Indianapolis, Kukua, Kalihi Valley, Hawaii, North Lawndale, Chicago, Southside Chicago, Taos, Pueblo, and Williamson. And it's very exciting that all communities here are represented today, except for Southside Chicago. But we just value your time again. So some outcomes of the Listen and Learn tour are to create relationship maps for each community that highlights the core principles, social determinants of health of key focus, and really the key partners that you work with to advance your health equity agendas. In addition, we are building a platform of shared learning, and we will continually network the communities. Tomorrow, we're having a breakout session with the community representatives to talk about what some sticking points are, what technical assistance you could use to advance your health equity agenda, if there is some missing key piece of information that you could glean from the other communities, and really just how we can continue to work together moving forward. And then we also want to identify communities for our next level of work, which is the Communities in Action Network. And so during this phase, we're going to pair some of the communities we visited this summer with other geographically nearby communities that want to advance their health equity agenda, but are really just starting off. And the NAM has facilitated a similar process. My colleagues Kimber Bogard and Ivory Clark and Gloria Wonying, if she's in the room, they work with a set of 10 states to develop plans to implement recommendations from a 2015 Institute of Medicine report on transforming the birth through age 8 workforce. So it's something that we've done before, something that we're excited to do again, and I'll just note that this activity is really rooted in the science, so it all goes back to the report, the Communities in Action report that we talked about earlier. Okay, so enough context. Now I'll turn it over to my panelists, and we'll start with Ezra to provide a brief overview about community context and what social determinants of health you focus on in your community.
Well, good afternoon, and thank you for having me here today. First, I do need to recognize one of my tribal councilmen that's here today, Mr. Martinez. Thank you so much. He's one of our tribal elders from Taos, Pueblo. I'd also like to recognize any other elders that are in the room. I don't think I'm there yet, but I'm getting there. But to all of our elders who have paved the way for us and have done so much fantastic work that makes our work a little bit easier. But I'd like to recognize any of you that are here today and those that have gone beyond. I also want to say, obviously, I am a non-native. And I can't tell you what an honor it is for me to be able to speak on behalf of Taos Pueblo or for Taos Pueblo with my councilman's blessing and my governor and my war chief as well. So it is an honor to be here today. I do work for Taos Pueblo. We are a small tribal, I'll say reservation, but I'll put that in quotes, located in northern New Mexico. We were just talking about some of the rural communities. We are very rural. I think we're considered frontier by our federal government sometimes, which I'm not even sure what that means. But we're 2.5 hours from our nearest airport. We're tribal population of about 1,700 people that live on our tribal lands, and we have an enrolled membership of about 2,700 people. So fairly small. We are located geographically adjacent to the town of Taos. I actually live in Taos, not on tribal lands. And I put reservations in quotes earlier because I do think it's a distinction that we need to make. Well, first of all, you know, there are 568 federally recognized tribes in the U.S. I don't know how much of a historical lesson I need to give, but just so we know, tribes are sovereign nations. They have a unique relationship with the federal government due to the treaties that have been signed over the past 250 some odd years. And it really gives some unique power and authority to tribal governments. That said, there's 568 tribes. They are all different. I think a lot of times we see, especially in the world of curriculum and policies and all these things, it's like, oh, this is a Native American curriculum, so it must work in all of these communities. And they are all unique. They are all different. So I'm speaking on behalf of Taos Pueblo, and what works for Taos Pueblo may or may not work in other tribal communities, because like I say, they are all very different. One of the things that is, I think, special about how we work at Taos Pueblo is that we are a self-governance tribe. And what I mean by that is that for years, Indian Health Service, primarily in the Bureau of Indian Affairs, kind of did healthcare or did government programs to tribes. They were the implementers of these programs, and they were the funding source, and sometimes they were even the employees, and they would come into tribes and do these programs and then leave. And that was how healthcare was done, or that is how law enforcement was done, or that's how the tribal courts was done. Taos Pueblo, really starting in 2007, so we're still kind of new at this in some ways, but Taos Pueblo has taken all of those responsibilities, or most of those responsibilities, from the federal government, has said, you know what, Taos Pueblo knows better what Taos Pueblo needs to solve the issues that we're facing today. And so we're going to implement those programs, and we're going to operate those funds, and we are going to tell the federal government what it is that Taos Pueblo thinks that is important, and how we need to run those programs in kind of a culturally aware, culturally sensitive way. Just one brief example of that, and then I'll turn it over. In 1998, there was the Special Diabetes Program for Indians, which may be the worst federally named program that's been, but it's really a pretty interesting program in that the federal government did allocate diabetes prevention programs to tribes, but they still had their fingers in there, and they were still kind of telling tribes what they should do with these funds. And they basically said, do cooking classes for adults, and that's how you're going to prevent diabetes. Taos Pueblo back in 1998 said, we want to do primary prevention programs for kids. We want to have sports programs. We want to have kids going around. And literally the Indian Health Service was like, no, you can't do that. That's not an allowable use of funds for diabetes prevention. It's like, really, you can't get kids running around and exercising to do diabetes prevention. But that literally was the conversation we had to have 20 years ago. Anyway, that's just one kind of example of where this federal oversight of tribal programs has kind of created tension between the tribes and the federal government about how tribes want to operate their program. And again, in 2007 and then again in 2009, the tribe at Taos Pueblo has taken on all of those responsibilities from the federal government, most of them, not all, and it has operated the programs in the way Taos Pueblo sees fit. So I think that makes us a little bit unique. I mean, about half the tribes are doing some sort of self-governance, but just for context.
Darrin?
I'm on now? All right. Thank you for letting me be here today. I think this is the third time in 3 years I've had a tie on, so I haven't been doing this much lately, so I apologize for stumbling along a little bit. The community I'm from is in the heart of Coalfield, Appalachia, and the last 30 years their population is a third of what it used to be. Severe unemployment is in double digits, thousands of people leaving the area. Our efforts in health, though, came from community development efforts, which started when they mentioned I was mayor earlier. We realized we didn't have a plan. There was no plan to do anything. If there was a crime from the extraction industry in where we live, is most of the property is owned by absentee companies that don't live there. So as they extract the wealth, it's not reinvested in the community. And there's no really plan to diversify those communities. I think if you look across the country, though, you see other examples of communities that strategically grabbed that responsibility 40 years ago or 50 years ago and planned to diversify their local economies based on what their assets were. Were they highways or rail or whatever those assets were that they had in their community. So we quickly realized we had no plan and no idea where we were going to go and what our future of our children would literally be. And 10 years ago, this year, we were designated a blueprint community. The program was sponsored by the Federal Home Loan Bank of Pittsburgh and the Benedum Foundation. We put together a group of volunteers, and we went and learned how to develop strategic plans. And through that process, we started realizing that we had some bad health demographics and what was causing those. And one of our visionaries was a medical practitioner, and they were talking about creating this education clinic. And kind of accidentally, well, not accidentally, but the early progress we had was from developing grassroots efforts. We didn't have any money, we didn't have any capacity. So we would recruit volunteers, take advantage of VISTA programs, things like that, get people in the community to try to increase that capacity. And through looking at what our weaknesses were, we saw those as opportunities to get funding to affect change, make things happen. And one of the early programs was a diabetes initiative, the Southeastern Diabetes Initiative. And the interventions that we did were basically just education, health, what not to eat, what to eat, replace your soda with water, and imagine what it, what it does for you, and things like that. But the progress was so evident that it started getting attention. And anyway, we looked accidentally through just relationships and the people we met along the way that worked with us, and we met somebody where the idea of using a federally qualified health clinic to increase access to health care and generate revenue. Well, that revenue provided people like me that didn't get paid to do community development work a way to get paid to do community development work. So I don't work in the banking industry anymore. I'm not the mayor. I embrace the X part of the mayor, thank you. There's a lot of aggravation that goes with that kind of thing. But we still do community work every day. And now it's, more of a career, so we change in what we do. But the bad health issues we had and those that we saw our weaknesses as an opportunity to create revenue to help sustain the work and make things happen just to get started. So as we've gone along the way, though, the Culture Health Prize was very significant in that you start meeting other people and other examples of what's happening, other ways to do it, learning how to do it. But we always intended, when we were developing our sustainability initiatives, we started developing our health initiatives, we always use words like replicability. Collaboration was at the basis of it. One of the first lessons we learned, I think one of the first projects, like the second month I was mayor, we painted light poles. That doesn't sound like a big deal, but there was this Main Street beautification program that was done 12 years prior to me taking office, and those poles were still primer red. So Dr. Beckett and I got together and said, hey, we're going to paint these poles. We figured out how to do it. We got estimates so we could approve it without getting the boards. We just got it done, Then the garden club started calling us. And they didn't like the color we picked. So Dr. Beckett and I looked at each other and we said, we didn't get the community's input in what we did. And that was like, okay, we got to start getting an organized plan and get everybody's input, together to what to do. But for the last 2 years or so, with looking at replicability, it's been an honor really to kind of be an ambassador for Culture Health Prize and talk about the impact that it's having, not just in our community, but across the nation. And then our intentions always were to be like a leader. As a county seat, we're a leader in the county, and we would like to replicate and explain how we fail forward, to learn and do what we can do to make our communities and places a better place to be.
Great. Lisa?
Is it on? Yeah. I live in Brownsville, Texas, which straddles the Rio Grande River and an international border. And literally my office, I can look over. It's like a stone's throw from the border fence. And our walls are not figurative. We actually do have a border wall fence in our community. And so I think that's really kind of a symbol of some of the barriers that our community faces. We are a fast-growing, young, and poor community, and I can rattle off the statistics, which I think, reflects a lot of places that we come from, but we are the poorest metro area, the most obese, the most diabetic, the most uninsured. Over 60% of our population has no payer source, no insurance. We don't have a public hospital, although our region is over 1 million people, and if you count the Mexican side, we're over 3 million people. So we have been disenfranchised for a lot of years. The area was originally belonged to Mexico, and so families are separated by the river and now the fence and soon to be the wall, which is as we speak, groundwork is being laid, through our wildlife preserve to build the first segment. So I think I learned, from the awesome panelists and speakers today, some terms jumped out at me that sort of describe our community. We do have the weathering effect. I think we have a very hardworking population that's used to walking around very sick because of our burden of chronic disease, and you become used to that. I think people think that that's the way you're supposed to feel. They think it's normal for people by age 58 to either become disabled from their diabetes and be pulled out of the workforce because they've never had any access to care. Our federally qualified community health centers have oftentimes a 2-year waiting list for access, and it really is an access issue to the max in our area. But we recognize that that's not changing overnight. We don't at this point because of national policy and because of our population, which is over 90% Mexican or Mexican American. Families are divided, like I said. Most families have someone living on the Mexican side and part of their family living on the US side. We have mixed immigration status families, so it's not that everyone is undocumented. Much of the family were born in the US, but they may have one family member who, has either recently joined or didn't have the luxury because of families coming back and forth to work, of getting that status. And so there's a lot of stress in our communities, particularly right now, around, that one family member. So children are carrying a lot of that stress because we have become more and more militarized. We have a huge law enforcement presence in our community. Detention centers. We have influx of refugees, coming from Central America, and unfortunately, there's kind of a disconnect and around welcoming or not welcoming those folks, and so, complicated issues as we've heard about in all of our communities. But some of those terms include the weathering effect. I think the violence and the fear and the stress and feeling sort of disenfranchised. And in our great state of Texas, we have been sort of historically literally kind of at the boot or at the bottom of the state, and resources have not flown in an equitable way, given our very young, vibrant, hardworking population. And so I think, but in spite of that, we are, like I said, a hardworking community, family-focused, very bicultural. So we have a lot of cultural richness that we are proud of in our community, and we have beautiful natural resources that have not been highlighted. So we are on the Gulf of Mexico. We have a lot of nature and space and green space that is quickly developing because we're so fast growing. And so through kind of a university, city, and community partnership, over 10 years ago, we created an advisory group that was pretty multi-sector and pretty representative of our population. And we were able to take data. We never had a research institution. I work for a regional campus that opened up in 2003. And that was really the first local research institution serving that large region. And so we didn't have local data. Many of the national surveys and the state sort of data that's collected didn't dip down, didn't sample enough for us to get a good picture of our local statistics. And when we started doing that research in a pretty systematic way, we found that the burden of disease and obesity was, of course, much higher than had been reported. And that, of course, coupled with the other social determinants of health, our high poverty and all of our challenges that you know about. I also want to mention, so anyhow, we came together, and I feel like we did get some momentum. We won the Culture of Health Prize, Robert Wood Johnson Prize in 2014. We're very proud of that. And we were able to take some of the policy, environment, and system change efforts that came out of that collaboration, and now we're working with 9 small towns and municipalities in our county and region, and we're sort of taking the best practices and bringing those historically very divided, never talk to each other mayors and city managers together with a little bit of creative use of 1115 waiver funding from through the state to kind of create the momentum around these changes. And through that collaboration and bringing those cities together, some things have resulted that we didn't think we were working on initially, but are actually turning out to be what is the glue that keeps our region sort of moving forward. One of them is called the Active Transportation and Tourism Plan. So we initially were talking about health, using community health workers and doing some really good work, using the media to work on behavior change. But that quickly morphed into an opportunity in the natural resources that we have in our area. It's a great birding region. Okay, I'm being stopped. Anyhow, okay, well.
Thank you all very much for that overview. So my first question is, how does your community define health?
So I was thinking about this question. I mean, I think we really, at Taos Pueblo, there's kind of 2 ways I think we would define it. I think there's an individual definition. And one of the things that is so unique about Taos Pueblo is that, Mr. Martinez gave us the prayer this morning. That language that you heard is over 1,000 years old. Taos Pueblo has been there. The North Building is at least 1,200 years old. I mean, we're talking about a culture and a civilization that has been there for literally over 1,000 years. And that there is, I hesitate to even call it a religion because it's such a way of life. But there is a culture and a tradition and a religion that is really a day-to-day thing. And I think that there is a definition of health. There's obviously the mental and the spiritual and the physical and all that, but there's also this underlying tradition and culture and religion that happens in an everyday way that really needs to be part of how I look at health programs as a non-native about how are we supporting that in ways that we can, because that is such an integral part of the day-to-day. The other definition that I think is really unique there, again, because this community has been there for time immemorial, over 1,000 years, is that there really is this perspective that, we talked on it earlier, and it's almost accidental that this happens, but we are in this together. There is such a community feeling there at Taos Pueblo that if the whole community is not healthy, none of us are healthy. Again, they've been there forever. They rely on each other for that strength and for survival. And I really think that community, the community strength and the community infrastructure is part of the health discussion that goes on at Taos Pueblo. So that's how I would define it.
If I say FQHC in this room, I'm pretty sure everybody knows what I'm saying. I don't have to come out and say Frederick Law Health Center, but Williamson Health and Wellness Center, some people will say we're an FQHC. Well, I like to say that we're a nonprofit that operates an FQHC. Our mission talks about the holistic health of the community, creating economic opportunity or employment opportunities for a new way of thinking what those opportunities are. The traditional industries, you didn't have to have a college education to necessarily earn a substantial living, a substantial income. Even though your employment may be somewhat erratic, you could still make a significant amount of money without furthering your education a great deal. So parts of our rural communities, though, don't have access to internet. And are they going to subsistence farm and live in those places, or are they going to create some other way to create wealth or have an opportunity to educate themselves or even be part of a 21st century economy in those places. So we take our revenue and try to create ways to create these new opportunities or get assistance from maybe facilitators or other organizations, or seek outside investors or whatever to try to help improve everybody's opportunity to have a better, more level playing field, to be able to stay and live and work and play and do those things.
Really hope for the future of children is how our community defines health. Will my children have an opportunity to have an easier life than I did? And that's still really where we are. And I think it's reflected in the fact that when people do have an opportunity to build a home, even if it's in a colonia or a rural area, they always leave the pile of bricks next to their home, or they have rebar sticking up, because that signifies that we're always going to be building to the future. And I think they're having that sort of hope, and my family will be with me. We'll have a house for my children, close by. And so to the extent that people can feel engaged in that, being around for their grandchildren, having opportunity for their children in the future, that is how I've heard from people in our community the definition of health.
And based on your community's definition of health, what kind of discussions do you have around the social determinants of health? Do you call them the social determinants of health? Can you call them the social determinants of health? And health equity, is that something that enters the conversation? During our travels, some communities were very front and center and oriented their conversations around equity. Others, not so much. So what would you say is true of your community?
I don't think we have those conversations per se, but again, I mentioned the self-governance process, and one of the things that we're required to do by our tribal council is community consultation. Again, we're a small enough community that I think this is a functional method. But every year, throughout basically the first kind of 6 months of the year, I am required, my staff is required to have community consultation with tribal members. What do you see as the issues going on in the community? Where do you want to see improvements? What's going on in your life? What's going on in your family's life? We're required to have these conversations. They can be done by survey, one-on-one, in community meetings, but we're required to glean this information from community members. We bring that information together, and as kind of a staff, we have about 40 of us on staff, we set annual priorities for all of our programs. There's 9 programs under kind of my division. And we have a full day meeting as a staff about what we're hearing from the community and what they're seeing these issues are, and how through these 9 programs that are under me address those issues. So again, we're not really having the conversation about what are the social determinants of health and kind of high intellectual in some ways conversation, but it's what's going on in your life, and how can tribal programs, how can tribal government affect those issues. And again, how we implement that is, again, I have these 9 programs. We start with a home visiting program. We go to the senior center and kind of everything in between, public health, nursing, and behavioral health, social services. And we really try to look at multifaceted programming to address these issues, and not the siloed effect that is what has happened with how the federal government set up these programs originally in tribal communities was, you got money to do your transportation, you got money to do your senior center, and never the two shall meet. We know that people don't have programs that are siloed like that. So again, what the tribe has told me to do, what the tribe has told us to do as programs, is solve these problems for our community members. We don't care if it's the transportation driver that's solving the substance abuse issue, just solve the problem. So we really look at it from a multifaceted way. But again, getting that community input at the beginning of what those issues are informs our programming.
In the early days of developing our community development work, I agreed to speak at a sustainable energy conference one time. And so it was a small room, and everybody in the room, what's your name and why are you here? This guy says, hi, my name's Freddie. He said, I'm a retired school administrator and elected committee man. I just want to hear what that guy says. And he points at the mayor, all right? So we were talking about sustainable energy. And I said, Freddie, I'm talking about putting solar panels on the water plant because I don't want to raise your water and sewer bill. So I had to make it real for him. With declining populations, government services are paid more per user. Your rates are going to go up per user because you don't have as many people there. When it comes to health, though, our focus now is shifted more toward health because the health is the anchor institution that's kind of driving, greasing the wheels and driving our machine for us. It's our fuel. So it depends on who we're talking with. In the city proper, the smaller community of about 3,000 people, I think one in 5 residents live in public housing. How many of those residents are children? So then we're going into schools, and if we get into a bigger area, then you're talking more about substance abuse. They're coming to our community to acquire those substances. Another nonprofit agency wanted to establish a recovery home in a former hotel building. Well, some of the powers that be fought that, and they didn't like it. And most of them were not people of, they were people of means. They had income and things. And we don't want those people here, and that kind of conversations was going on. But those people were already there. They were ODing behind that building. They were ODing in the parking lot at the gas station and in these different places. And their perception of what was actually happening in the community, they weren't that well informed. So we do a lot with workforce empowerment, opioid recovery, and those kind of things, trying to create opportunities for people besides the bad choices. I noticed we make choices a lot of times based on the choices that we have available to us. So we repeatedly saw people that would get in trouble earlier in life and come back and end up right back doing what they were doing before they got in trouble. So how do you change that environment for them to give them a better opportunity? That's part of the efforts we're doing to create like accelerator or innovation hubs where they can get expertise to have their own businesses and not get back into things. There's one of the drug counselors that we've been working with lately, and he was a former drug dealer. And I was at a town forum. It was his first opportunity to speak to the community, and he made a formal apology for being part of the problem and the scars and the things he'd done. But yet that was powerful. But now he's taken he's realized what he did. He got his education. Now he's part of the solution. He takes pride in the fact that he's paying taxes. He takes pride in the fact that he's helping his neighbor not be in addiction or get over his addiction and realize the error of their ways. So a lot of ways, you look at it in many different levels, just depending on who's in the conversation.
We don't talk directly about the social determinants of health. I mean, maybe at our sort of advisory board level. But I think the advisory board has really tried to engage young people and neighborhoods and communities that haven't historically been in the conversation, and that has really led to some different approaches. So we're data-driven, we're research-driven, but the solution we found only works when it comes from the folks that are living right in the neighborhoods and communities that we're working with. And I think one thing that our young people have kind of taught us recently as we've engaged them more directly is that, particularly I think in Texas schools, there's this sort of forced acculturation, and our local, the kids have really lost a lot of their, amazingly, the vast majority of kids enter school in our community first language Spanish, and many of them, by the time they leave school, don't feel comfortable reading, writing, or speaking that language, which is really tragic when you think about the loss that's there. And so engaging kids and youth in going back and learning their history, their disconnection from the land. These are, many of them, their parents and grandparents were agricultural workers. Many of them come from migrant farm worker, formerly migrant farm worker families that have been now settled, or their grandparents in Mexico were farmers. And yet there's a complete disconnection to the land. And so those are the issues that we're working on with youth and with young people that I think do address social determinants of health, but we don't speak directly about them.
Great, thank you all very much. So we only have a few minutes left, and I would like to open it up for audience questions. We have time for 2 very succinct questions. So we've got one in the front here.
Thank you. I'm curious about if you guys do any political education with your bases, particularly to understand how race and fear of immigration, fear of changes in our economy are being used by the public, the larger discourse to undermine support for policies that would actually rein in the corporate drive for greater extraction and greater exploitation. I was just curious if you incorporate that into your programming in any way. Maybe not that language, but in some way.
I'll just speak to race for a second. West Virginia is very low percentage-wise in minority percentage of population, under 3%, I think, is a state, under 2% in the county that I live in. However, the city that I live in is much more racially diverse. I think 14% all minority races. So racism, bigotry is pervasive because of that small percentage. So we intentionally bring it up as far as an issue. And people say, well, why do you? Because we need jobs, we need money. I said, but we still have this layer of hate, and we have this layer of, that we need to just bring out. So we create forums and opportunities for it to be made aware just for the greater cause.
I guess I can't, I think there's a lot going on because we're a pretty large community, and so there are a lot of sort of movements going on, particularly around immigration. We have a huge DACA population, of course, because folks come and then get trapped. We have checkpoints about 90 miles north of our region, and so it used to be that you could kind of make it across the border, but there was a second border there. So we do have a pretty engaged young population, although for many of the reasons that I was talking about in terms of our educational system does not, it's a pretty traditional sort of, I would say even repressive system that really kind of silences that. And so there are some groups that we're working with that we're purposely, in terms of the multi-sector board. One is called the Equal Voice Network, and I think it's actually part of a national movement. And again, they are leading us in those conversations, and particularly with our youth. And again, that's really, I think our young people are really leading the way, which is neat, because we're a young population and that's the way it should be. So formally, I think only to the extent that we kind of connect with them and support them. But we're a pretty homogenous population, but of course, immigration is on everyone's minds.
I'm going to take a pass on that one.
Okay, sounds good. One more brief question, anybody? Oh, Hortensia.
Is it on? I can't tell. Yeah. Thank you for a really fascinating set of issues that you've brought up. I'm aware of sort of the fine line that community-based organizations walk in terms of positions that they can take in terms of some of the issues that have been brought up here, and really kind of pushing up against some of the powers that be, because at the same time, community-based organizations often rely on state and city funding, and so perhaps some of those very officials or other stakeholders, maybe the business community, that may be actually either contributing to the problems or opposing some of your proposals for how to resolve the issues. And so I'm wondering how you experience that, how you manage that, and sort of what keeps you sort of from going over that edge of being co-opted.
So the road to self-governance was not an easy one for the tribe at all. Again, I just got kind of involved with it again in 2013, so I missed some of the original stuff. But we still have annual, we call them negotiations with both Indian Health Service and the Bureau of Indian Affairs, BIA. We have them annually to discuss the issues, to put it politely. They still want to exert a lot of control and a lot of financial control, and the money still passes through their offices. So there's always this give and take about the financial resources and how come they haven't come to the tribe and what is the tribe doing with them. So we meet annually, and they've gotten better over the years. People aren't leaving the room in anger, and which they were previously. But it's a constant negotiation for us with the federal government about, this is what the tribe thinks is right. You need to get out of our way and let us do it. And the Fed's saying, well, this money is allocated for this program, so you need, how does your spending relate to that program? And from a health perspective, I mean, I feel like I get to be fairly creative with that, especially in the prevention world, but it's still a negotiation that happens on an annual basis with the feds and I need to show why the tribe thinks this is a prevention program. This is why we need to fund art and music in an after-school program using the diabetes funds. And how is that related? Again, that's my job to show, but we negotiate and argue with the feds every year on kind of why we do the things we do. And it doesn't always go so well, but we usually win.
Great. And with that, I ask you to join me in thanking the panel.
Great. Thank you, everybody. So I know we're a little bit over time for the break, but what we're going to do while we're taking our break and grabbing a cup of coffee is we're going to get our online community engaged in responding and asking questions via poll everywhere. And obviously, folks in the room can do this as well. So what we want to know is we want your comments or questions about challenges or solutions that have been found to transfer across communities. Communities you work in, communities that you know about, communities that you've heard about. We're going to be collecting all of these, and then our staff is going to be reviewing them. We'll be summarizing a lot of this. And the full summary, by the way, of this meeting will be posted online. You can find our January meeting as well. The webcast is archived on our webpage. So these will be as well. So I don't want to cut you any shorter than 20 minutes for your break because biology. So I will give you 20 minutes, but at 20 till, we will start abruptly. So exactly at 2:40, and we'll try to make up that time in the afternoon. Thank you.